Okay, well, thank you everybody for coming. Hope you're enjoying your sandwiches. And as you can see, there's loads. So feel free to take some for later, for tomorrow, for your families. We're all about sharing the love, sharing the food. So yeah, I just want to say I'm really glad this day is here. This has been a lot of work in the making. Brett has seen a lot of my face over the last few months. So just thank you to him, and thank you of course to Azizi, who is our fearless leader of the Department of Informatics and Health Data Science here at the University of Miami Miller School of Medicine. And yeah, let's just get started. So I suppose we are going to maybe shift the agenda just a little bit, just due to, I suppose, the nature of time. You know, you guys have lives, obviously, and we're not trying to keep you here forever. But this is just kind of the outline that I had planned for today. If you didn't already know, there is kind of an online portion of this that contains kind of a bit of background reading, some questions just to kind of check that, you know, things are kind of making sense. But it really just outlines kind of the nitty-gritty details of what is a digital therapeutic? How does something go from, you know, just software to software as a medical device onto, you know, not only just a digital wellness app, but into a digital therapeutic, and as Shaheen will talk about later, a prescribed digital therapeutic. So there's some really juicy bits in there, could put you to sleep, but I think it also kind of ties into, you know, the background of what we're going to talk about today. I wanted to just give a little bit of background about myself and my journey to what today is. So I moved to Miami at the end of October last year. I originally applied to work as a clinical research coordinator. So things have, you know, shifted and changed. Just to let you know, I still do work as a clinical research coordinator on a main study, but I've got a lot of other hats that I wear within the department. Primarily just the lead of the clinical operations and dissemination aspect of what we do at the mill and in the department as well. So I suppose just to kind of highlight what that mission and vision looks like on my end. So really what we're trying to achieve is to, you know, look at the different technologies that are evolving, innovate, accelerate, disseminate accessible and effective health and wellness technologies for all. So that looks like a lot of different things. That looks like products. How do we push it out to as many people to benefit as many people as we can? That looks like coming up with ideas of, okay, you know, we have a population that has these health needs. What can we develop in order to address these needs? In, you know, any sort of software, an app, or even just reaching people where they're at can be the primary sort of aim for a project that we are looking to do. So the vision really, again, to improve patient outcomes through technology and innovation. We live in a very technically advanced world. Everything is changing every day. It evolves so quickly. So how can we really make that work for us and our patients? Especially within the sphere, you know, we see so many people from so many different backgrounds, with so many different needs. So how can we lighten that load, work smarter, not harder, as they say? And then just the values that we kind of prescribe to is being a leading voice in healthcare technology and innovation that is trusted by all. So how do we link the three together? And how do we ensure that what is being created for the people and not just being created for the sake of creating or being created for a profit? So we really have people at the bottom of our hearts. Everything we do, we hope to just give it back and improve people's lives and the outcomes of just, yeah, I suppose on a day-to-day basis. So I just want to say our department is kind of, I suppose, divided into 5 different verticals. You'll hear me talk about it. You'll hear Azizi talk about it. And we really hope to achieve things by kind of stratifying them into 5 different areas. So as I said, I'm kind of the one leading the code is what you'll see there. So we have kind of 3 primary areas that we're focusing on. So remote health monitoring, decentralized care, that also ties into my research project, decentralized trials, and then as we're talking about today, digital therapeutics. So what we'll touch on most today is between kind of a blend of the education and then the clinical and dissemination portions of our department. But we also have sort of 3 other overarching themes that kind of dictate, what projects we get involved in, or just different sort of missions that tie into our overall vision. So we have in attendance our very talented social outreach coordinator. So just shout out to Mary, who is also in the hopes of starting medical school very soon. And she does amazing work. She and I work really closely together in order to take what we're learning, the products that we're testing, researching, and actually deliver them to the people. We're all kind of working together. So, it's all about educating people. It's all about going out and promoting these events, but also hearing what they have to say and hearing what their needs are as well. It's not just a unidirectional sort of interaction. We want to make sure that there's nothing for the people without the people is what I like to say. So, yeah, I know Azizi's going to speak more to the other verticals maybe briefly, so I'll leave that to him. But I wanted to say that this module was really created as a part of a larger vision to really introduce students, the future clinicians, future, students in allied health, to the principles of innovation and technology as relates to the medical and allied health world. Azizi and I attended a really nice conference that was led by the University of Miami medical education curriculum sort of team about, it was a really nice session in there about how ChatGPT, what are the risks, what are the benefits? And I really enjoyed that session. So I want to say, just thank you for bringing it up, because we need to talk about it. It's there, it's evolving, and students, they're not immune to it. They're not naive to it, so how can we, make it work for us and not treat it so much as something to fear or suppress, but how can we use it to make our work easier, better, and more accessible to people? So the Media and Innovation Lab, in partnership with digital solutions companies, we're aiming to encourage students to pursue the actual potential of these digital solutions for clinical application. We're hoping to develop, further curricula and apprenticeship opportunities with the various companies that we're, in partnership or in collaboration with, for future medical and allied health professional opportunities to, again, just to explore and face it head on, as opposed to say, oh no, I'm a doctor, I don't need to know anything about technology, that sort of thing. And then again, just my huge sincere gratitude to Click Therapeutics for showing up today, and you're helping us to pioneer our first session, so thank you so much. And again, they've got really lovely information to share just about their own mission and vision and how they've gone about creating products to help people where they're at. But again, I'll leave that to the expert. So I just also, this is all on that online learning module. There's no way you're going to read all this. So there's no way I'm going to read all this to you. But these are kind of the learning objectives that guide, or that helped us to kind of shape the curriculum developed today. So we have a lot of, theoretical points that are being brought up and discussed today, but then there's also this applied piece where we want students who maybe haven't heard anything about software as a medical device or digital therapeutic solutions to kind of say, oh yeah, I'm learning about this. This actually sounds pretty cool. How would I be able to maybe, learn more about this, work with it, and maybe even use it in my own future practice? So we do have a bit of a discussion section carved out. Again, I think we're a small enough group that we might be able to just come together and have a bit of a group discussion. So I don't mean to throw you under the bus, Brad. If you want to lead that, that'd be great. And again, I suppose after today, if you have any questions, feel free to reach out to me. Myself, Brett, Azizi, we're very happy to receive your feedback. There is a feedback survey at the end that I know Brett's going to flash up. So again, any feedback, things you liked, things you want to learn more about, things that you thought was a bit too maybe much for an intro section, we're all ears. We only want to move forward with this. So again, I just appreciate your time and thank you for being here. And with that, I am going to pass it over to my boss, Dr. Azizi Salacious.
Thank you. I don't think, well, first of all, good evening, everyone. I don't think Rachel has ever called me her boss ever. We don't roll like that. We roll like we're a startup. So I think we believe in horizontal leadership. So first of all, I am very excited to have you all. So thank you again to Click Therapeutics, as well as our senior leadership, as well as our fearless leaders, Brett and Rachel. I am seriously sandwiched by greatness. A little bit about Rachel that I think she may not state. So we have this philosophy in our group about leadership, where when we interview folks to be part of our group, we oftentimes share with them that we believe in a 70-30 rule. And what we do is that we believe that 70% of the efforts and responsibilities that people take on are those that they can do in their sleep, right? That in many ways, it really allows them to flourish, but they can do these things. And so, you know, what Rachel has spoken about, yes, she serves very well as, you know, one of our clinical research coordinators, but the 30%, I think, is the best component of how we lead our team. We believe in stretch responsibilities. And what does that mean? It means, therefore, that we try and tap into talents and growth areas. So when we interview people, we do a SWOT analysis and we're very transparent with them during the interview process. And when we hire them, and we have a kind of a onboarding process where we walk them through what we thought their SWOT analysis looked like. And we basically try and find a green space that highlights where their stretch responsibilities are. And one of the areas that Rachel shared, and you know, we're just so lucky to have her, was the fact that even though she is a licensed, board certified rather, occupational therapist, that she really wants to get into the space of innovation, because she believes, based on her track record, you know, going to school here in the States as well as in Europe, that it's important that we use innovation as a way to serve everyone. And so she has been tremendous in leading the effort, particularly the clinical operations dissemination and e-health. E stands for electronic health as well as emerging health. So I just want to give her a huge shout out, and a huge shout out to Brett. You know, Brett is, as you all probably know him, if you don't know him, you should get to know him. He is a paragon of what a true medical student looks like. You know, my father-in-law always said that you need to dress for the job that you want, not the job that you have. And Brett is the living embodiment of that he is already a junior faculty in my eyes. And when he decided to join our group, that he said, you know what, I want to roll up my sleeves proverbially and, you know, kind of get to work, because he sees the value of the U and what the medical education, particularly our next gen medical education, can offer, and what innovation with sprinkled in that can offer as well. So Brett, huge congrats to you for putting this on. So I'll just kind of move through a little quickly, because in light of some of the issues. So as you know, we got here about 1.5 years ago from NYU School of Medicine, and Dean Ford essentially said that we want you to tackle an issue for us, or several issues. And the issues weren't just specific to the University of Miami, but it's actually a global issue. How is it that we can reimagine academic medicine and healthcare, particularly when you look at very vexing healthcare challenges like health disparities, whereby individuals, because of their demographic in terms of who they are and where they live and who their parents are, where their family lineage is, and oftentimes don't actually get the necessary access to healthcare and good quality care. And when you look here in our own backyard in Miami, that 20% of individuals are uninsured. And that doesn't even scratch the surface of how many individuals are underinsured. And when you look at that in relation to the stats nationally, about 10% of the US population is uninsured. So we're twice as more likely to have folks who are uninsured, which means therefore that access is a huge issue. And so that's a very important issue that as a medical school, you have to, and we have to try and tackle. And that's one of the visions of the Department of Informatics and Health Data Science, that we want to be able to do that. But in addition to that, what we do recognize as another challenge is that we have a shortage in the healthcare workforce. It's estimated that in the next 10 or 20 years, that we will have less than 3.2 million healthcare workers that will be needed to serve the growing healthcare needs of our nation. And so what you end up asking is that, well, as my colleague, our associate dean has done, is we need to train more folks. But we know that the pace of training doesn't track really step for step with the pace and need to serve individuals. And so it means, therefore, that we must use innovation and technology to meet this gap between how many folks we have to serve and how many people need healthcare. And this is one of the important challenges. And so the perfunctory question is, can technology and innovation help to solve some of these vexing healthcare challenges? And our thesis as the Department of Informatics and Health Data Science and the Media and Innovation Lab is that yes, it can be, but these are tools as well as innovative processes that will allow us to solve some of these vexing challenges. In addition to that, we have some significant opportunities at hand. So when you juxtapose the challenges, that there's some significant opportunities as well. What are they? Well, improved decision-making. Using data, informatics, and technology can help to increase and improve decision-making. You know, particularly when you look at the shortage, as I had referenced before, of healthcare providers, it's partly because healthcare providers are getting burnt out because of this overwhelming amount of paperwork that needs to be done. And so it can get in the way of improved decision making. Precision medicine is also another opportunity where we can use informatics as well as big data and technology. Improved patient engagement is another area. And then lastly, in terms of population health management. And so just wanted to share that because of those challenges, as well as opportunities, we created the Precision and Personalized Population Health Framework. This is the framework that guides all of our work in the Department of Informatics and Health Data Science and the Media and Innovation Lab. And initially when we created this, this was more of an analytical and a scientific framework that allows us to be able to say, how is it that we can do a better job in seamlessly translating discoveries into treatments and solutions? And we do that analytically by saying, how can we learn from the population to inform the individual? And then how can we learn from the individual to then inform how we understand the population? And so what you see is this iterative process using data, informatics, and technology to help feed discovery, as well as help to translate these discoveries into treatments and solutions. What does this look like? It means, therefore, that in order for us to really catalyze and to accelerate innovation, that we must really double down on how is it that we're going to go about discovering? How is it we're going to create disruptive types of findings as well as innovation? And we have a fantastic framework in our department that lays out the continuum of insight when it comes to discovery, all the way from description to optimization using advanced mathematical modeling, as well as machine learning and the like, as well as simulation modeling. We won't bore you with that because that's not the focus today. But what we want to be able to show is that when you actually have deeper understandings through insight, through big data, through informatics, this will then allow us to do a better job in terms of informing people, making people more aware of their health conditions. And how can we use technology to do that? And in the Media and Innovation Lab and our department, we are using some of the most cutting edge types of technologies and processes how we can increase health literacy and education and awareness to some of our most vexing healthcare challenges. Similarly, how can we use informatics and data and technology to improve prevention, access, assessment, as well as acceptance for treatments, as well as adherence? And so this is kind of our broad vision, and we've been doing some work already in this space. I won't bore you, but we did this work when we were at NYU, and we've continued to do this and actually force multiplied all the different artifacts and products that have born out of this precision and personalized population health framework. But it's not just enough to create new analyses, new products. What we recognize that one of the foundations of being an academic health center is that we must make our educational framework and our curriculum more robust. And when we did our SWOT analysis, we said, what are the different modalities that are practiced or taught in academic health centers? Primarily, it's the scientific method, the engineering method. But one of the things that we want to say, and we are very bullish about this, is that we need to incorporate the scientific method as well as the engineering method. But we truly believe that there is an innovation method as well that needs to be actually interwoven in academic medicine. And the reason why that is critical is because we see the next generation of physicians or providers and scientists being a new phenotype, what we call clinician innovator and scientist innovator. It doesn't mean that, although we would love it, that you create a new product and you spin it out and it's patent and the like. That's helpful and that is good. But we also believe that innovation can be, if you want to start your own clinic in the middle of Kansas, how is it that you're going to actually bridge the digital divide? How is it you're going to make your clinic a better catchment area for people who may not have access? And so this is where disruptive innovation comes in. And here are some areas that we have some curricula around. How is it that we sustain innovations? What does disruptive growth innovations look like? What are some potential for products, as well as the efficiencies in innovation? We have 6 theories that we have highlighted. We're not going to be talking about those today, but for future problem-based learning, we're going to be showing people how is it that you innovate. We don't believe that innovation are just God-given talents, right? No one should have a monopoly on creativity, but instead we believe that innovation are skills, are ways and processes in which you can actually learn and innovate. So there are arbitrage. I won't go into them at all. There's arbitrage, right? There's viral, there's tipping points, and there's some others as well in terms of boundary work. At another time in another problem-based learning, I'll go into details about this. But what we're saying is that we have curriculum, theory, as well as application, and we're going to be working with a company called StopServe, who actually has an innovation platform that can bring teams together to help to facilitate more innovation and to accelerate how teams innovate together. And so with that, I have a question. And I think, you know, and it's up to Brett and Rachel if they'll allow me enough time to do this. But if we were to say, what digital health solutions have you seen or used in the past? And what elements worked for you and what did not? And you don't have to answer per se, but I want you to think about this because it's really critical for you to understand why is it that innovation, because some people may have this sense of innophobia, right? And it's really, you know, innovation phobia, or people may have technophobia. And what we're saying is that technology in its simplest form is making complex things simple, right? And so we want to be able to demystify any form of understanding, or, you know, people may have that, no, this is not for me, this is for the cool young kids and the like. We're not saying that. And we're, you know, thanks to Mayor as well, we're doing some good work with our older adults in terms of making digital literacy a huge, you know, component. The other question we have is, what health information can be communicated effectively remotely? And what health information or services are best provided in person? And what you see in the questions that we're asking is that we truly believe that if we were to teach the innovation approach and the innovation framework, the kinds of questions you're asking are nuanced questions. They are not kind of binary categorical questions like, is technology good or bad? And I think this is where, in order for us to accelerate and to make the University of Miami Miller School of Medicine be the leading you know, voice in innovation, that we need to embrace technology and innovation wholeheartedly, and it needs to start with education. So the last question, where do health practitioners come in? with the implementation of health technology into clinical work streams. This is critical because one of the things that we see is that it's not just about the creation of a technology, but it's when are you going to use it? How are you going to disseminate? How are you going to implement that technology in existing work streams and workflows? Because that's technically the rub that we get when we do our listening tour with clinicians. Yeah, this looks good, but should we use this in my patient's home or should we use this in the clinic? And when should we use it? At what dosage? With whom should we use it? And I think these are some of the more nuanced types of questions that we want to be able to ask and answer. And we've done so in our paper that highlights the pan-theoretical framework. And what does it mean? It means, therefore, a pan-theoretical approach where we have used this approach where it's not top-down theory or bottom-up theory, but it's both, whereby we have led several projects whereby we have used big data and technology to improve and increase personalization of healthy lifestyles. And we've published on this, as you can see, and we've also used it in a way in terms of how is it that we can address many of the gaping holes that we see in healthcare delivery. And we published this paper, the second paper in COVID, and we were instrumental in leading that effort. And so why is this important? Why is this course important? Why is it that we're hosting this? Why is it that we've invited Click Therapeutics and their fantastic Chief Medical Officer, Shane, here? It's because in order for us to realize the vision that I just previewed, and you haven't even seen the full extent of it, we'll as time goes on, we'll reveal a little bit more because we want your help to help us to crystallize it. But the reason why we have a session like this is because it starts with education. If we want to create paradigm shifts in how medicine is practiced, it must start with you all. And I'm looking at the med students here and the folks in residency and the like. It starts with you. Why? Because education will serve as this dynamic and catalytic force that will lead to new standards of care and practice. But it also means that education is not enough, that we need to be collaborative. And this is why, thanks to Rachel and Brett's leadership, that instead of having me teach, a seminar where everyone listens to me and falls asleep, that they wanted people to be here to collaborate. It's more collaborative learning. And it's important because this is our moment. I think the University of Miami is at a watershed moment. Why? Because there's so many forces that outside of our control that are occurring. That Miami, thankfully, has become more and more a tech epicenter and an innovation epicenter. And what we've done in our landscape analysis is that every flourishing ecosystem has a very strong academic institution. And we have to be that. University of Miami, in not just through me, because it's not just me, but this is where the collective comes in, that we all are striving to be that. And I was going to say an institution that's north of us in an area, with a ton of schools, and we're going to go west. But what we are saying is that we don't need to benchmark with the Stanfords and with the Harvards and the MIT. We can set our own standard. Why? Because Miami is the gateway of the Americas. That we are not just playing in the, kind of the backyard of the Americas. We are the center of the Americas, and it's critical that we seize this opportunity, and we have to do it here. So yeah, we're a small group, but we want that because it's intimate. That we need you all here to be early adopters with us and to go ahead and preach the gospel saying, hey, we have some really cool things happening here. Let's try and use this as an opportunity where can generate more momentum in technology and innovation. So with that, as I said, I sandwiched by greatness, and Brett, is one of the best medical students that I've worked with. And I don't think I've said this to you because the team sees me in a different light sometimes when I'm on meetings and I don't get to floor them. But Brett is such a fantastic I was gonna say young man, but it means that there's that age difference and we don't believe that, but you're such a wonderful person. Just recently got married and he did not miss a beat. You know, we've been preparing for this for like 3-4 months. And this gentleman, when he was on his honeymoon, was still sending stuff. And I'm like, dude, like, oh, sorry about that. Yes. No, but I'm not lying, but no, we gave him space, but no, Brett has been just amazing. And just want to say, there's no greater joy having, you know, mentors see mentees flourish and just kind of sit back. So with that, Brett, I'll invite Brett to come up and to lead the next step. So thanks, Brett.
Thank you, Azizi, although that hurts me to, I really, Dr. Seixas, I'm sorry. I have to say doctor, that's just ingrained in me.
All right. Okay.
Yeah. So our idea for, today really is to highlight one aspect of innovation, which is digital innovation in medicine. And we wanted to do that in the spirit of the next gen curriculum that we've been developing here, which is through case-based learning, case scenarios, and discussion of that sort. You know, given the intimate gathering that we have, we'll go through this a little quickly, but that was our idea. And really, when Dr. Lakan Shaheen, see, I did. Wow. Yeah, I'm trying. I'm trying. You know, when you speak, I'll ask you to think about your solution that you're going to present from that patient perspective and how you came to that as a company and as a new innovation as well, keeping in mind the case scenario. So this is the scenario we have with you're a provider, a neurology specialist who has a heavy caseload. You have a new patient by the name of Maria, a 25-year-old single mother whose chief complaint is recurring episodes of pulsating head pain on one side of the head, 4 to 8 times a month. The pain is moderate to severe and often accompanied by light sensitivity. The pain worsens with movement and can last up to 6 hours if left untreated. She reports that ibuprofen has been effective in relieving symptoms within an hour, but effectiveness has decreased in the last few months. And she also has nausea when the pain is more intense. She attributes her symptoms to poor sleep and stress and is very busy, going to dental hygiene school, a mother of a 9-year-old. She referred to neurology for further evaluation and consultation, but she refused to see a psychiatrist as she is culturally against psychiatric medication, also fears that medication will prevent her ability to breastfeed. That's a lot, you know, and I think those of us in medical school will say that you pick out a few main points when you're reading the case presentation and you're already thinking, this person probably has migraine or what could be migraine disorder. And she has a lot of cultural concerns, but also a lot of demands on her time, and treatment may be difficult for what she's doing. So what are some newer options and what can we think of to help someone with this situation? We had a lot of questions here for group discussion, and we can do this. You know, we're developing a curriculum and this is the foundation of that. But really what I want to invite Shaheen to present is their solution for someone like Maria who needs help, who may not be able to see a provider often, medication may be difficult, and what are some novel, innovative strategies to relieve this kind of situation and help not just manage, but also potentially treat. So Shaheen, if you don't mind just speaking about it too. For the record.
Excellent. Can everyone hear me? Oh, I have a clicker too. So this is very natural for me because I love karaoke. And so this is kind of, and full disclosure, there's a venture capitalist in this room. Do you want to stand up, Maria? She's local from Miami, was actually one of the original funders for Click Therapeutics. So have to disclose that, but believe me, she has an open mind and looking for new companies as well. Oh, this is not that Maria. Exactly. Oh, I love it. I love it. Hey, a little bit about myself. Neurologist, pain management specialist, Boston based, but happy to be here. Hopefully I'll call Miami my home shortly. I was with my real estate agent earlier today, literally before Brett picked me up. I'll just tell you, I've I've lived so many parallel lives. I was a curricular dean and founding department chair of neurology for one of these more newer medical schools in Southern California. I sat in healthcare administrations, like established multi-state, well now national practices in addiction medicine with DaVita Health and Savita Health, in pain management clinics. So I got to see the business elements of this. I was on the payer side. I was on Virginia's Pharmacy and Therapeutics Committee, right? The ones who decide the $8 billion, which drugs do you put it on, which interventions, what type of treatments you do. And then for the past few years, I've been developing new ways to treat diseases. And not for the sake of novelty or copycat medications, mind you, like diseases that don't have therapies out there, period. No FDA approved or cleared solutions. Postpartum depression was one of them, with Sage Therapeutics, with at Neurocrine, it was tardive dyskinesia, movement disorder, largely associated with antipsychotics based use. I could go on and on, but last 3 to 5, maybe 3 to 5 years, it's been in this software as a medical device space. And everything is mission-based. I love, so what Azizi says resonates with me, because I truly just don't do it because I look at, oh, there's a total addressable market size. What's the most prolific disorder and which ones have the most affluent patients that could pay self-pay, frankly, right? You could do that in this industry. If we did that, we would not prioritize schizophrenia on our pipeline list, right? Like, absolutely not. So it's one of the driving factors. And it's a privilege today to speak with everyone here. It's a bit of a test run, right? To see if this formally gets introduced and how it gets formally introduced into the more formal curriculum. So feedback is welcome on the fly or when you're filling out the forms, essentially. So let's have at it, right? Great. That was introductions. This short primer on Click Therapeutics, not meant to be promotional by any means, but we are a digital biotech company, right? So there are biopharma companies that cultivate drug or biological assets. We do the same, but with digital therapeutics, meaning we discover them, we design them, discover them, validate them through a series of testing, get the regulatory clearances. Now the FDA is on board and has particular avenues for regulation, commercialize them, and collect the real world evidence to iterate, right? Because unlike drugs, you could actually change this configuration, right? And it has its own unique challenges because there's no clear playbook. Like, I'm not here to introduce a playbook to you. We're actually writing it. We're testing it as we speak. And there are many stakeholders. I'm today representing a developer of a therapeutics. You are representing every other sphere in order to make this a reality, right? Healthcare systems, individual practitioners, patients, right? Family and caregivers of people, with lived experience with these types of diseases, right? A little bit about myself. So I still do keep academic appointments, because I think it's important. I like kind of giving back. So largely, like most of my time now has been in Morehouse School of Medicine. Just got their neurology GME program going. So July 1st, they'll have their first residents. Really excited about that. But a few others. I used to be at Virginia Tech, was chief of pain management. So I keep that neuroscience. They became a little bit of my discovery engine for new drug development. And my nonprofits are largely about, actually, it's competency-based education, and not just for higher education, right? Like, we have some forms of competency-based. In fact, I was just talking to your simulation chair or director, Barry, and you made great strides. We have OSCEs and we have other assessments. I'll tell you, you could introduce this even in early education, K-12, preschool, essentially. Why do we have these constructs of grades and state-based standardized, examinations for promotion type of purposes? If you could attain those factors earlier on, you should be able to be on your own trajectory, right? Your own timeline. So that's what I'm actually doing at Centers for Collaborative Education, and so on. I used to be a former curricular dean, as I mentioned too. Okay, let's talk about the migraine treatment landscape, because this is very relevant to that clinical vignette that you saw. Younger patient, right? So 25 years old, breastfeeding, has some concerns, episodic migraines, right? Because it's like, within this, 4 to 14, not greater than 15 monthly migraine days. She had all the classic features of Was it the aura that she experienced, the high intensities, unilateral sounds and lights, phonophotophobia that came along with it? Now, migraines has gone through over the decades a transformation. It used to be, okay, it's a headache disorder, everyone gets headaches, right? Into a bona fide neurological illness that has a distinct pathophysiology, right? Neurovascular structures, neuroinflammation, vasoconstriction, dilatation, and then a cascade, a wave of cortical spreading depression. I'm not just saying these are marketing terms, these are all part of the pathophysiology. And once you define a disease in that sense, it opens up targets. And the targets could be biologics, drugs, and I'll introduce now digital therapeutics that could do that. I'll say psychiatry is on the verge of their diseases, right? Our diseases, all of us, of being described in these terms. And it's not going to be ever. I don't think there's ever going to be just a structural correlate. You know, you have increased gray matter in your hippocampus or anything like that. It's going to be, as Azizi says, there's going to be different signatures and profiles because right now we're dealing with a spectrum of diseases. And unless your therapeutics factor that in, this is why you get failures when you loop up so many heterogeneous disorders that we call a single label, major depressive disorder, schizophrenia, bipolar disorder, all of these types of things. And we studied it. We're diluting all the effects of individual factors. That's what Aziz is going to change, right? In the long term. Yeah, we all will. I love that. I love that. Well, migraine also disproportionately affects women. And there's a variety of reasons. I mean, hormonal implications have been made. Also, women have a tendency to have more functional deficits. So if you take the same number of monthly migraine days and you stratify it, right, based on sex, really in this case, then you'll find that women actually have more productivity impairment, more disability, quality of life, and other factors. We'll get to that. But if you don't recognize that each of these different variables and parameters of an individual has different outcomes, then how are you going to tailor a solution? This is why I'm mentioning some of these that are going on board. And migraine, I mean, I could never remember a single person presenting with migraine without a comorbidity. There's always concomitant insomnia or even hypersomnia, right? So all of these have both sides of the equation: anxiety, depression, other pain syndromes, hypertension, you name it. And it's a huge, huge disorder. Like we have around 40 million Americans suffering from migraine. So it's actually one of the most common neurological presentations to any specialist or primary care providers is migraine. Okay, so I kind of established it's a bad disease, right? And then here are the barriers. So we have to recognize this, that how much % of folks that actually have migraine seek care? How many of them receive this diagnosis? And how many of them, once you get the diagnosis, actually get delivered a management plan and they carry out on that management? It's dwindling, right? Multitude of factors. I can't say that there could be safety concerns, cultural barriers, access barriers, transportation barriers, all of that influences it. If you look at adequate specialty level care, I know mental health is like this epidemic, right? And COVID has accelerated it, and that's why White House has put, mental health on its forefront of priorities, and hopefully they match that up with administration funding to address it, right? It's one to call a problem. It's another to put your money where your mouth is and actually invest in solutions there. Sadly, migraine is part of that, right? So you have a mismatch of the folks suffering from the disease and providers that could actually address it. Or what's the biggest mental health workforce? Primary care providers. What's the biggest migraine workforce? Primary care providers. Giving them adequate tools that they feel comfortable with as well. And we'll talk about that shortly. So you really segment patients because there are different, resources that you want to offer to different patients. So episodic versus chronic, and there are different pathophysiology that goes on to it. Level of disability, if you don't ask that or don't collect that, you'll never be able to intervene on it, right? And we'll talk about that. And then that describes when you have to use different types of therapies. Here, this is not meant to go through this algorithm, but it shows you, if you don't respond to acute therapy, or you're using acute therapy on a very regular basis, then you got it. And it's so logical, right? Then you got to do something that prevents the migraine, right? Like, we don't want needless suffering. And we want people to have good quality of life and return to work or school and family and all of these other type of things that goes on. So then they move on to this category, and we call it preventative treatments. Now, we have a few lines of preventative treatments. This is important. You know, whenever you see a disease, and there are first line, second line, third line, fourth line and base therapies, what does that mean? Yeah, I would love to hear. It's challenging. It's challenging to multiple stakeholders, right? One is a challenging disease, which has the burden that's incompletely addressed, right? Because at first, if it stopped at first line, there would be no further lines. Two, the challenge could be, well, you have efficacious solutions, but their safety profile is pretty bad, right? So let's try things that we know might not be as efficacious, but use those earlier because they don't have that, or it's a risk-benefit type of analysis. There also could be financial, impediments, right? That create what we're going on. We have highly efficacious and safe solutions that are put in the last line because, frankly, we do have rationed care, right, in the United States. And if we introduced everything at the sticker price that every biopharmaceutical company put on board, already, it would not be, 30% of our GDP would be healthcare expenditure. It would be 70% or something of that nature. So somehow we've taken some of the population health type of principles and say, hey, maybe it's better off actually putting on board. And we'll talk about this in a second. These are a list of the preventative migraine treatment options. And this includes everything from new and old. Are you guys familiar with the new CGRP inhibitors? Okay. Well, this is the first time that there is a targeted treatment for migraine based on its pathophysiology. So CGRP, calcitonin gene-related peptide, is a pain hormone that's kind of released and regulates the neurovascular structures. For the last 15 years, I remember I used to do early discovery research on this. We've been trying to target it. There's across the blood-brain barrier and so on. For the last 3 to 5 years, that's all gone through phase 3 research and so on, and now made it to formulary. Maybe you've heard of Nurtec, right? That's by Biohaven and bought out by Pfizer. Well, that's on here. That's essentially, the one that's listed over here. It's a small molecule oral formulation that's used for acute and preventive therapy. But this is what I want to show you on this side when it goes to results. MMD stand for monthly migraine days. And what we're trying to do is reduce that, right? Someone starts off with 15. We're trying to get that down. Essentially, we like 0, but we look at 50% response rate. So at least get a 50% reduction. If you look at propranolol, which is a beta blocker, has been around forever, right? And has been genericized forever. They're all in the same range. There's not been material improvement in efficacy throughout the decades of migraine therapeutics. And this just shows you, right? Like, it's just like data. I didn't have to do anything further about it. And even at the end we're introducing some cephaly and gamma core. These are neuromodulatory or stimulating devices that one triggers the vagal nerve, the bottom one, and the other was a TENS unit that's applied right over here on the frontalis muscle, essentially applies it. Even those solutions are in the same type of thing. So here but you're probably wondering, well, why do they develop it? Why does it exist on formulary? Why are people actually paying for it? They have a better safety profile, right? So this is one disease where you're introducing new lines of therapy. Unfortunately, they're in the same efficacy range, right? The monthly migraine days reduction, but they're getting safer because the earlier ones were causing, actually in heart disease, you can use triptans and beta blockers. You could have heart rate reductions and blood pressure reductions and so on and so forth. I show this, it's anecdotal, but it's so illustrative. There is a patient advocate, you could Google it. She goes by Migraine Diva, and she's taken her pain, and no one's paying her to do this. This is just herself. She's suffered so much from migraines and has gone from therapeutic provider and therapies, where this is what she travels with on a daily basis. And if I show you everything that's on there, there's over the counter, there's NSAIDs, there's Tylenol, there's prescription solutions. There's these devices that happen there. There's this gel hats, and you put that in the freezer, and then you put it on your. They try everything. So people don't want to just spend money on these things, right? It's because they're suffering and there's an incredible need. It's very powerful, the migraine diva story. And it's not, believe me, and maybe because I get higher end of the migraine spectra, I see this routinely in my patient experience. So this kind of prompted the whole digital health industry to talk about, can we create apps that one, maybe track and monitor kind of diseases, and you'll talk about some of the wellness apps and so on. And then some on the verge of, can we actually treat, go to the pathophysiology, correct the mechanism of disease that's going on board. And that's what this next part is supposed to do over here. I'm going to skip some of this over here, but this is important because this is nomenclature. And this is like the style that you have to leave with, essentially. Digital health applications are ubiquitous. I'm going to call your EHR. What EHR system are you guys using here? Epic? Oh, great. Okay. So you joined the Epic bandwagon. That's a digital health solution. So it's any sort of technology that supports, you know, the utilization, delivery, integration of healthcare. And that could just be behind the scenes, back end, you know, of data exchanges, or it could be patient facing, could be provider facing, could be health administrator, billing and coding facing, doesn't matter. Those are all digital health type of technologies. A subset of that are digital therapeutics. Now, who here has heard of digital therapeutics before you kind of, yes? Saw this talk here. Okay, maybe you heard of it. So digital therapeutics, there's something called the Digital Therapeutics Alliance that put out a white paper and definitions around there. So this is any software that manages, prevents, or treats the disease. It could be used independently or in combination, right? So adjunctively or as a monotherapy with other therapeutics that comes on board. Then there's even a smaller niche that's called prescription digital therapeutics. So how I describe these are, one, it's in the name, the prescription. They have to be prescribed. They're generally for serious diseases, not self-management of anxiety or coping or lifestyle type of things. But two, the evidentiary bar is high. They have to create the phase 3 type of robustness, internal control type of study that needs to happen, right? And there's a regulatory pathway for them because now they're going to make a healthcare claim. In the United States, right, there's the FDA that has statutes. You cannot just go out there and say, hey, this works for you, unless you're a supplement, because there's some special provisions for that no, truly, like in the legislation. But digital technologies, you can't. So the FDA said, let's treat software as a medical device. And we already regulate medical devices, right? Like the robotics, the Da Vinci robot that does urological surgery and now other type of surgeries has to file application with the FDA. So what the FDA did is create one category for software as a medical device, and that's what PDTs go through. And so it has to create not just safety and tolerability, but efficacy, essentially. Okay. And these are the 3 pathways these could be introduced in market, or they could be used by you guys, right? Standalone. So there's a single filing as a software as a medical device, and the application is standalone. I think the best example of this is, think about insomnia. Do you know what the gold standard treatment for insomnia is? Gold standard. Hey, I'll just fill you in. It's not the Ambiens. It's not the Z drugs. It's certainly not benzos. It's not the Rameltions or anything of that, or mirtazapines that happens. It's CBTI, right? Cognitive behavioral therapy for insomnia, a specialized curriculum, right? That incorporates actually sleep hygiene, sleep restrictions, behavioral changes, and cognitive restructuring that happens. So you don't ruminate and have this anxiety and everything that goes on. That's gold standard. And believe me, every professional society, it's listed. This is a perfect disease because you guys didn't know about this. Patients don't know about this. Patients, let alone, don't have access to CBTI providers. And I mean, there's a host of reasons why that's the case, but let's just say that's the classic mismatch. We know of something that in face-to-face delivery is very efficacious. It's in your guidelines, but patients don't get access to it. So clever companies then said, I'm going to standardize this. I'm going to put this into an application, and then I'm going to test these into the trials and generate that evidence. And you have solutions like Sleepio and Somrist that are on the market that are doing that and getting traction that's out there. That's standalone. Complementary actually means now I'm going to be adjunctive to standard of care therapy or class of therapies or something of that nature. And let's take, for instance, I'm not meant to be promotional, but I just the first example that comes to head. We have an MDD product, major depressive disorder product. Now, if you know that there are SSRIs, SNRIs, there are these standard types of drugs that are used for major depressive disorder, but not everyone has a full, complete remission or response to it. So we developed a solution that is exactly adjunctive to MDD for those incomplete responders, put them into a phase 3 study, and now I can officially say we just filed with the FDA for regulatory clearance there. That's a perfect complementary, but it's not married to a particular drug, whereas combination they are. Now, there are these drug device combinations. In fact, if you think about it, there's smart inhalers that Teva has created, right? So that gives you exactly what's the metered dose, right? It actually gives you feedback. What was your forced vital capacity? What was your expiratory capacity? What's your lung volume? All of these other type of things that come back. That's a drug device combination. Here I'm presenting, we can do the same thing with a software only based solution. And you file the regulatory clearances with a new drug application. And it's a combined efficacy and safety signal. We're on the brinks of getting to this area. And what I relish about this talk is, I wish I had this talk, but not with digital therapeutics because it wasn't conceived when I was in medical school, but with biologics, with CRISPR and genomic editing. And then I'm sure my predecessors with small molecules and their predecessors, right, with just ethical pharmaceuticals, right? Before it was pharmacists making concoctions and compounding. Without this, it takes a generational lag before new therapies actually get employed and get even better, right? Only when these biologics, remember when, Humira and Enbrel were around, we had highly efficacious solutions for rheumatoid arthritis and IBD and Crohn's disease, but it took around 10 years to get real good traction. And I think that's because the physician base and frankly, the patient base did not drive a demand because there was a lack of awareness. We're bridging that. And we should bridge that. Yeah. Let me know if I'm saying anything controversial. If you don't disagree, I love that we can make a debate if you want. I'm fine with that. Now this is key. And this is how I started off with. I do happen today represent this part here, but I'm trying to be non-promotional. We all represent the other spheres over here. Patients, caregivers, HCPs, caregivers, health systems, payers, and pharmacy benefit managers, the P word. Policymakers, and then us as manufacturers. If we don't get, and I intentionally showed alignment, but this takes a Herculean effort to get this alignment. This is an ideal future state. And it's gonna, and it's not gonna, it shouldn't be actually just driven over here. There's a budge of what the needs are over here. I'll talk about why digital therapeutics try to cater, right? With co-design, with implementation studies. We would love to test these in human factors research in the actual clinic, right? Do you need a patient care navigator? Will the patient understand it if a doctor says, hey, you get prescribed it, you get an access code on your smartphone, you download it before you leave the session or your video visit with a doctor? Like, would all be work? We need to get there. Okay. Oh, to this, I see. And then here are advancements being made in access. I don't expect you to read this. I want to distill it in these slides here. There's impending legislation that's been proposed, Bipartisan Access to Prescription Digital Therapeutics Act. It was actually Senator Jean Shaheen from New Hampshire, which is a co-sponsor for it. It's actively being discussed right now to push it forward. CMS has accepted codes, CPT codes, right? Reimbursable codes for remote therapeutic monitoring. This is a perfect solution. So unlike pills that don't talk back to you, digital therapeutics can, but it's really, is it giving the information you want as a practitioner and you want as a patient? And what can you do to make better treatment decisions in either of those situations, whether you're a practitioner or you're a patient? AMCP, if you're not familiar with it, this is the organization that does clinical pharmacology and pushes to it. They've been driving access. And I already talked about the White House mission. In fact, digital psychiatry is on the top 5 priorities for the White House. Now, evidence generation plan. whenever you, and this is meant to be now, if you're going to introduce a new therapy, what do you have to do to get it through the hoops to convince all of those? And it's actually not to convince, to collaborate and align with all of those stakeholders, right? It used to be all you have to do is generate evidence for regulators. That used to be the thought, right? I'm going to tell you, there's a lot of approved solutions there that don't get any traction out there in the real world. There's a lot, and I actually don't want to name those. Yes, essentially, right? And this is where you got to do things differently. And that means when we have the luxury of doing drug or therapeutic discovery, you do a lot of hypothesis generated type of research. Like we had to test in our migrainer population, would people with migraines actually just allow an app to sit on their smartphone? Would it allow it to collect passive data, their sleep, wake cycles through the sensor, their actigraphy or movement data, their geolocation, not to be Big Brother, but to see their social distance, right? And are they leaving their house? Are they going to work? Are they going to school? These are the type of reasons. And we had to introduce humanism essentially into this type of approach. Every data that we try to collect, we have to inform them why it's not just beneficial for people like you. Because a lot of people saying that, right? It's going to help you in population health. A lot of these folks are like, oh, well, I'm suffering actually right now, and you're collecting my data. And yes, you're asking for informed consent, which is great. But what's in it kind of for me at this moment, in my moment of need. So you kind of really have to show that. And that's called usability, acceptability, feasibility, and human factors type of research. And then you could also then segment it. Am I going to generate a solution that is in a particular area of the biorhythm? For instance, in migraines, you have a headache, but before the headache, you have a pre-headache. You have aura. Before the aura, you actually have this premonitory syndrome, where it's a little bit of brain fog, there's autonomic dysfunction, things that's going on. And then before that, there's interictal. You're not entirely at baseline. There's cognitive disturbances, sleep disturbance, everything else. So when's the right time to design the solution? And then Azizi, I saw on your slide, digital biomarkers and phenotyping, right? If you try to create a one-size-fits-all solution, I'm just going to say it's an exercise in futility. You definitely will fail. And if you skip this hypothesis phase and say, hey, I know my stakeholder, I know they're going to use it, I know when they're going to use it, I'm going to build out that solution, it's going to fail. It's just going to fail at one point. And so this is the phase-based approach that we're taking. And it's a model. It's a model that could be used across the board. Phase 0 is that proof of mechanism, usability, that stuff that goes on. Then you have a product concept. Rather than building out the full solution, build out essentially what your key mechanism of action is and do a fast fail type of study. Recruit a handful number of patients that are representing of your population and then see, are you moving the mark on your endpoints essentially, right? Then you could build out a phase 2, which is now a few weeks, not just the mechanism of action, but now a therapeutic experience. I'll tell you, because I know you talked about humanism. I think that the very almost secret sauce of a good digital therapeutic is something called the Therapeutic Alliance. So this is borrowed from face-to-face therapy, and I'll even say it from more psychotherapists. And they broke down what leads to good behaviors and good outcomes, right? I wish physicians would think more like this, essentially. And they broke it down to 2 things. One, there's this trust, rapport, and bond, and it's measurable. And okay, so patient came to me for headache management. Well, okay, he's board certified neurologist. He has good credentials. He's hired by a hospital, which is legitimate, and he knows his stuff, for instance, pass. 2, likability. Okay, hey, he's kind of personal. He relates to me. He's asking me right questions, pass. And this is the 3rd part, and this is the one there's a lot of failures. A shared functional goal. When your patient's goal is not the same as your clinician goal, it breaks down. And that's oftentimes, can I tell you, most sessions, no one's even asking you, what do you want? Oh, so you have diabetes and blood pressure? Okay, I'm going to try to reduce those types of things. Oh, you have chronic pain? Well, it's probably going to be reducing pain. They just wanted to be able to lift up their grandchild or something like that. If you did break that down, their shared functional goal, and then break that down further into small steps that they could take to reach that shared functional goal, you lost the therapeutic alliance. So when we build our solutions, it's all about creating this therapeutic alliance in the first few weeks and then testing it. They're now validated measures of the therapeutic alliance. And I'll go into that in a second. Once you have that go ahead, and this is all stage gating, right? Because think about it. There's capital, there's money on the line, there's time on the line, there's opportunity costs on the line before you move forward. You need to know what your decision points are before you go or don't before you forward. In fact, I know it's a business principle, but we should really apply this across the board in everything that we do, in projects that we do. Otherwise, the folks that, refuse to say no to anything, they accumulate so much, they get diluted. Then you see the work product, right? It shows essentially. You got to instill in some go, no go decision points in your mind. Great. You move into the phase 3 randomized trials. Just because these are digital solutions doesn't mean the evidentiary bar has to be less. In fact, dare I say, any new modality of medicine, your bar is higher. Not only you have to prove the efficacy, safety, and tolerability, you have to know now that it'll work in the existing workflows. You don't have to create a brand new one because that's a huge lift, moving mountains. Does it work in existing workflows? And last but not least are these post approvals and personalizations. But the bottom, I think I want to stress this the most, real world evidence collection. These can be done with digital therapeutics at the same time, because with pharmaceutical assets, you have to wait for market authorization before you do these longer term type of things. But because of the inherent safety, you could now doing in a real world study. Ideally, I would love to do studies with, for instance, University of Miami as a IDN or a healthcare network, its own patient populations and stuff of that nature. So while I'm doing the phase 3, have a very pragmatic, open, very unrestricted type of situation there, but with safety controls and collecting these, not like every 2 weeks, you have to come into clinic and get this. This could be all behind the scenes type of collection, right? Of data collection. And then you could change the product to improve it. That's moving on board. This is everything that I just explained in the past in a nutshell. Pre-development, there's a lot of things. Market access research, proof of mechanisms, and user research that feed into this evidence engine and then go into your evidence generation apparatus, essentially. Very important is the health economics. So we as physicians have to get really good at reading health economic literature, because if you leave it up to payers, let's just say they'll usurp kind of your rights and decisions, and they interpret in a different vein, right? And when I talk about health economics modeling, you have to look at cost benefit analyses, right? Cost offsets. This is important because frankly, every new therapeutic that comes into market, it could either be additive on costs, right? It could be actually not just either, but additive on costs, cost neutral, or actually cost offsets. The holy grail is offsetting something, not just adding to what is out there. And the way to do that is you have to prove it out in the real world. Am I taking something away? Am I preventing a catastrophic event that requires ER visits, safety visits, right? Am I supplanting a very high expensive cost therapy that's going on board? And it's beyond modeling and simulation. If you do the real world evidence studies, you get actual based data that's coming on board. I don't want to go into this, it's too scientific, but these are the generators for migraine. And we are working on a solution that's working from the top down. When I say top down, it's working at the highest cortical levels of how do you attend to your mood, your fatigue, alterations of cognition. Very basic principle. We all should apply this to our lives. Migraines happen when there is an imbalance. So everyone has homeostasis, right? You could imagine yourself, you probably get a little cranky if you slept too little or even slept too much. If you change your hydration, if you change your workouts regimen, you see that? And it changes your resiliency. And the same, so migraineurs have a vulnerability. And if you change this allostatic load, it's called, then you reduce your resiliency, and then they can flip into a migraine much earlier. So everything about this solution is to regulate all of these behaviors. And so they don't break free. Now that could be very easy. In fact, in doctor's office, most of the time they say, keep a routine. Here's a headache diary, goodbye. I'll tell you 99.9%, actually, no, that's giving too much credit to physicians. The ones that are actually saying this are giving e-diaries and stuff like that and asking patients to monitor it. That's probably a third of all practitioners. But we have the technology to record all of this, give you the instant feedback so you can make it, right? And tell them. There's a lot of confusion in migraine on what is a trigger versus what is early migraine, right? Fundamental difference. You probably all heard chocolate and all of these other type of things. I can tell you, most people with migraine, chocolate is not a trigger. We've done randomized studies actually giving the ones that self-identify as chocolate as a trigger, give them chocolate or give them something that's not cocoa-based but has a bitter taste to it. You don't get migraines. So these are the type of things. And you get anxiety. If you're just doing trigger, tracking and monitoring, can you imagine, oh my God, did that have MSG in it? Oh, I don't know. Like, right? I go to a restaurant. No one's going to put their complete list of ingredients out over there. Oh, that was too little sleep, because now everyone has these Auras and Fitbits and Apples. It was eight hours and 5 minutes. I'm 5 minutes over it. We don't focus on trigger. We focus on regulation and patterns and behaviors, essentially, that goes on board. Okay, I can move on. And we went through these stage processes. I just want to introduce this. Now I could present this because this was the American Academy of Neurology and next month accepted to be presented at American Headache Society. This is the proof of mechanism study that I'm talking about. We recruited close to 100 patients with migraine, gave them a 2-week experience, and then asked them to complete the tasks. Would they respond to the SMS and text-based system? Would they allow us to open the biosensors that's going on board? Lo and behold, most of them did, like on average, EMA completion rate, ecological momentary assessments, 30 out of 42. We were giving them 3 a day for 2 weeks, essentially. And so that equals like the 42 that's going on board. We also collected vocal biomarker samples. We talked about digital phenotyping. We were able to use just voice alone to predict whether they're in a migraine episode or not. The worst thing that you could ask a chronic pain patient, are you in pain and what's your pain score? That's the absolute worst thing. And you can read about it in all the texts about the opiate epidemic when it became the 5th vital sign. Then doctors felt that you have to intervene on it, right? It was actually the VA system, and then CMS kind of brought on board and joint commission. Then you had to intervene on it. What's available in your arsenal? Opiate-based medications, and that's how I had to do it. So rather than constantly asking about a painful state, we're trying to use passive biomarkers to measure, are you in a painful state? And not just a painful state, does it have a functional impact or not? Okay. Then we moved on into the phase 2-based studies, right? Now we built out that 2-week experience in a 60-patient population. And remember I told you that Therapeutic Alliance, and there's a validated instrument? It's called DWA-MARM. So Digital Working Alliance Mobile Relationship Agnew Measure, essentially. And it has a scale from 1 to 7. 5 to 7 means that you have a strong therapeutic alliance. And we pre-specified. We need a 5 and above. Otherwise, I'm not going to advance this asset. I could now tell our board member, Maria, that because we hit the mark. We got a 5.9 on this. And it gave us the signal, okay, they're building a bond, their relationship and trust, and they believe this solution will work. And I almost akin this to my drug development days. I have a biologically active ingredient right here in my hand, but it only works when it crosses the blood-brain barrier. And I need now a transporter or something to open up the blood-brain barrier. That's what this Digital Working Alliance is. Whatever you do after that, if you don't establish Digital Working Alliance, it will not be effective. And we put it to the test with many other studies. We also look at the migraine completion rate. I mean, I've not seen these figures, but truth and disclosure, migraine is a highly motivated population. They engage in solutions a lot, even tracking and all of those other type of things. But 87% completed daily migraine e-diaries. That's unheard of. And last but not least is these monthly migraine days and pain catastrophizing. We on an average a 2.2 monthly migraine day reduction when they used a very short experience over here. A lot of caveats, small study, open label, everything else. I would never go out and market this whatsoever, but internally, this was my go, no-go point to take my medical team, advance the full-fledged 12-week solution, add 10 weeks onto this, and go through everything else of the brain that I spoke about. Last but not least is pain catastrophizing. This is where I think digital therapeutics is so well suited because we have amazing anti-inflammatory agents that could block the whole cascade early and even late now, right? And we have every interleukin mapped with a monoclonal antibody. But why do we still have patients with disabilities, with rheumatoid arthritis, with Crohn's disease, with every inflammatory disorder? Because we're not rodents. Those were all effective in the rodent models and rodent brains that weren't worrying about their relationship, their finances, access to food, and everything else that's going on, right? The humans in the real world, and they catastrophize. That's what catastrophizing is, right? You're creating this larger, oh my God, this pain, I can't do this, I can't go to work. They're ruminating and having excessive worry about it, causing the insomnia and persistent anxiety. If you could reduce this, this is the holy grail between a mismatch of disease modifying agents and back to work and back to school. So I actually value that more than that figure, the monthly migraine days. And this is the last part, but we submitted this to the FDA, and this is actually what earned us a breakthrough device designation. I introduced that because the regulators are our partners, and they could be your partners too if you come up with solutions. They want emerging devices. In fact, I'd probably ask University of Miami, put some applications out there with your content for a breakthrough, and then partner with industry to carry them forward. It's like a beautiful avenue. I'm open for any questions. I think that concludes this part. Is that right? Oh, sure. Oh, it's a great stage. Well, one, they're all IRB approved studies. So please enroll in our phase 3 trials, your patients with migraines. So we've advanced this into a phase 3. And glad to say that last month we press released that we're enrolling. It's entirely decentralized. So it's a site-less model. It used to be, I don't know if you know clinical development, you have to go, you recruit maybe 30, 40 sites. These are the ones that have all the patients with your disease of interest. They slowly recruit. Unfortunately, it created so many barriers, right? Because one, you have to have patients that are within the catchment area, and they're generally metropolitan areas, so you already exclude a lot of the population. Two, you sometimes get what we call professional patients. That's the official term. These are repeat patients that somehow present with your disease of interest for all the studies that are going on board. That's not good, right? We don't want that. Those are not the real patients that are suffering with their disease. I could go on and on. So we created this more decentralized type of concept where you could incorporate this. So definitely send your patients for that trial. We actually are in partnership with the University of Miami in our schizophrenia asset. It's in partnership with Boehringer Ingelheim, and it's a phase 3 study. And I'm really proud to announce it's targeting negative symptoms of schizophrenia. If you're familiar with that, everyone talks about the positive symptoms, delusions, hallucinations, all of that type of things, because it gets the press, it's in the media, and so on. It's the one that, but most of the disability is coming from negative symptoms, the asociality, the lack of motivation, right? The lack of pleasure that happens over there. That's what disability is associated. And there are no approved therapeutics addressing this.
I think that was such a tour forth of what a digital therapeutic is, and thank you so much. So brilliant and so knowledgeable. And I hope you all had fun. I think, we really appreciate folks, hanging out with us in the evening. We want to respect people's time. Just a few things I wanted to share in terms of next steps. So here at the U, particularly in the University of Miami, we're doing a lot, right? And we want you all to be part of our group, be part of our team. And so our next event will be in the fall in September. We're actually going to have Dr. John White, Chief Medical Officer for WebMD. We're going to be showcasing and launching our new initiative called Information as a Determinant of Health. So we're doing a really cool project with them and hopefully YouTube Health and Google that we here at the U will be leading that effort. We have several projects as well that we're leading that you could just check out our website. We're doing a lot in mental health, digital therapeutics, as well as digital biomarkers as well. So feel free to speak with any member from our group. So whether it be Rachel or Mary or Brett or myself, we'd love to hear more as to how we can support the educational infrastructure as well. So with that, I'll just leave it to Rachel for last words.
Yeah, so basically, thank you. Just thank you so much for being open to this sort of session. And thank you everybody for participating, putting the time in, and just showing up. This is just the link to the feedback survey. It's kind of, there are elements that are linked to those learning objectives, but there is also at the very bottom, just a section to provide comments about, yeah, I want to learn more about this, but maybe in this sort of context, or, yep, this was a lot. Can we drill into maybe more specifics? We're totally open, totally open. And yeah, I just also wanted to bring up, like, Shaheen, you just say everything towards a functional goal. But like from an occupational, exactly, I was just gonna say, like, that speaks to me on so many levels because, we can get into the nitty gritty and, as physicians, as health professionals, we're always looking about, reducing symptoms and how do we improve outcomes and, this, that, and the other thing. But at the end of the day, it's people who just want to feel better. How can we make that happen? And I think in this sort of platform where we're just beginning, we're kind of starting to ask these questions about how can we reach people? A lot of people have phones, not a lot of people have access to, coming into a clinic. So what information can we get out there that's going to help them, at that first stage, that first point of care? How do we just make that better through the tools that people are already using, but that we can just improve and make a bit more, I suppose, streamlined? I'm open to discussion and I hope you guys are too. But yeah, I know my name and my, like, Aziz's name, Brett's name is all on that online module. It's on the Eventbrite that I know most of us use to register for the event. Feel free to shoot an email. We're happy to talk. We love to talk, and just share ideas. And we're always working on projects, always. So if you're interested in learning more, or if there's a project that maybe you're kind of thinking about doing, we're happy to even just have a bit of a think tank. And yeah, our doors are always open. So again, just thank you.